although we are able to often reduce a lot of the medications depending on the target site, and it involves implanting very fine stimulating leads into deep nuclei within the basal ganglia. That's for more in the center part of the brain. So we're nowhere near the surface, we're nowhere near the cortex. The size of the lead is about a spaghetti number 8 when it's limp. And then there's a second part of the surgery where we have to attach it to a neurostimulator about the size of a Zippo lighter, if you're that old and remember those. And that gets implanted on the upper torso, just subcutaneously underneath the skin. So all of this, of course, is done underneath the skin and covered up, and therefore there's no external ports or plugins or anything odd like that. And then ultimately, the device itself is programmed over multiple sessions to basically bring the stimulation up while we turn down the meds and find an optimum both of it. So that's what DBS is in a nutshell, and we're going to go into a lot of the different details. So we're going to talk about the DBS candidacy, which takes about a 4 to 6 month process from you first become interested. Then we're going to talk about the stage 1 surgery, which is the major surgery. A week later, followed by the stage 2, which is just probably much the standard surgery under full anesthesia, where we implant this extensions that are connected to the leads and implant the device, as I mentioned. And then a week or 2 after that, there is the DBS activation, an initial contact screen, which will be about the longest programming session you endure. And then afterwards, there'll be a series of successive post-operative management visits, more in the first year than successive years. But the whole thing about the post-operative management and the DBS therapy in general, it's not really a one and done. It's not just that you get the surgery and you're done. It's then that you work with us or other teams for virtually as long as you have the DBS afterwards, which, you know, we assume hopefully will be the rest of your life. So moving to the candidacy evaluation, which I said is like a number of months, the key points we're looking for are that you have a correct diagnosis, for example, of Parkinson's, idiopathic Parkinson's, as opposed to some of the other variabilities out there, which I'll explain. And DBS does not work to correct all Parkinson's symptoms, but it does work to correct the cardinal symptoms that people complain about the most: tremor, rigidity, and slowness of movement, also known as bradykinesia. We also need to know that the symptoms that you have that show up as Parkinson's are actually dopaminergic responsive, because if they're not responsive to dopamine, the DBS probably will not work as well or not work at all. And that also goes back to having a proper diagnosis of idiopathic Parkinson's. The next thing is, you don't just want to have an immediate diagnosis of Parkinson's earlier on in your disease state and get whipped off to our OR table. You need to have a reasonable exploration of the different medical therapies that are out there. Most common of which, of course, is carbidopa-levodopa in the form of either Sinemet, Sinemet CR, or even the newer Rytary. But there's also many other adjunct medical therapies that should be explored, and some people have numerous adverse effects to these medications, or sometimes become financially prohibitive, or across over time, they no longer respond as well as they used to, and you still suffer deep offs, and you become almost time-bound to your watch of when you're going to take your next meds. We also do have to say, DBS is not for everyone, and depending on the target site and evaluations, we have to check psychiatric comorbidities to see if they're well controlled, if they exist at all, as well as cognitive status, because it's essential that during the programming that we get appropriate feedback from the individual when we're working with them to be able to control their therapy, as well as if there's any adverse side effects that we're unable to detect, that the individual can respond and have a proper coherent conversation with us to indicate these things are going on. And then, of course, the surgery itself, it is brain surgery. And so we want to make sure that you are well enough and don't have many medical comorbidities that could create a barrier, or if it is somewhat of a barrier, that we'll be able to work it out and work around and see how we push through those. So a bit more in detail, when we talk about the correct diagnosis, there are many things that can masquerade as Parkinson's, Parkinsonisms, or Parkinsonian syndromes, such as dementia with Lewy bodies, multiple systems atrophy, and progressive supranuclear palsy, all initially present very similar to Parkinson's, and some will even respond to the Parkinson's meds. But soon, within 4 to 5 years, they will differentiate out. And like, for example, the reason we know that DBS does not work with MSA is that some individuals who were inappropriately diagnosed were given DBS, thinking it was Parkinson's, and basically did not get the benefits that they expected. And then some of the other symptoms of MSA showed up and said, oh, that's why it's not Parkinson's. And again, as I indicated, the 3 cardinal symptoms of Parkinson's, tremor, rigidity, and bradykinesia, are what we can help all the time. Other symptoms, such as trunk-based symptoms, are more to do with the balance or gait. We have a bit more difficulty working with. And again, if you're already suffering from some of the Parkinsonian impact on your voice, some of the dysarthria, or some of the dysregulation of the limbic system, dysautonomia, again, DBS cannot really assist that much with that. So it's important to match up the symptoms that DBS can help with versus what your greatest issues are in terms of your own symptoms. So again, if there's a not match to what DBS can do and what you want it to do, again, we don't necessarily want you going through the arduous surgery or the process only to wind up being relatively dissatisfied with what happened and the outcome is. And again, one of those key things, as we mentioned, is that the symptoms themselves are dopaminergic responsive. And so part of our process, apart from meeting with one of our movement disorder specialist neurologists and going through a long family history and history of the disease, when it first showed up, things like that, to help determine that it is idiopathic Parkinson's, is you will also undergo a Parkinson's challenge, a dopamine challenge, at another session where you would come in off all your meds, and so your Parkinson's would be at the worst, and we do an evaluation of your motor assessment, and then we would give you your standard meds that you take, and then see how much better you are on a second assessment during the same time. And again, that's something close to a 90-minute session, because again, even if you do respond to the medications, if you don't respond sufficiently, you will not do as well with DBS. So as a general rule of thumb, we often say that DBS will help you do as well as your best on time on your medications. Now, why would you want to do DBS if you don't get better than your meds? Well, that's at your peak of when your meds are working well. As you know, with medications, you eventually can become a slave to your watch and suffer some of the offs and the troughs, as well as the peaks and valleys as you go up and down with the meds. And what DBS is able to do is smooth all that out around the level of your best functioning of the meds, and we try to maintain you there. I guess the last thing we can say of dopaminergic responsiveness is you can have medically refractory tremor, meaning your tremor doesn't respond to meds, and that is the one symptom that still will respond to DBS itself and hopefully be able to be brought under control. Again, if you're newly diagnosed and you haven't tried a lot of the different variants or combinations that are out there, such as the MAO inhibitors or the COMT inhibitors, these are basically inhibitors of the enzymes that help break down dopamine, and are therefore, if you inhibit the inhibitors, you extend the life or the activity of the actual medications, the dopaminergic medications themselves, which sometimes smooths things out and helps prevent that as well. So there are a number of medical cocktails out there that could be tried or explored to see if there are adverse effects, or if you can be medically managed sufficiently. And so if you have not had that reasonable exploration by either a general neurologist or specifically movement disorder, we'd like to probably try that ourselves as well to see where we can get you if we think it hasn't been adequately explored. And again, this is where we talk again about the cognitive stability. And again, you go through some neuropsych as well as some psychiatric to see if there are issues. And if there are any issues, to see what can be done to support that and work around that, or if we need to change our target site because of that, because some target sites are less likely to cause further cognitive impairment than others. So, and then again, the surgery itself, the main part is about 3 to 4 hours long, and you are awake for part of it. So it's a long time to sit on our table. It's still a minimally invasive surgery, but it can become a very long and exhausting day. And we want to be able to ensure that we can get you through it, that if there are any cardiac issues or blood thinners, that we can manage those and get you through that. And so we need to work up that and see it. But as we often say, age is not a limiting factor itself, so much as how well you are at the different ages. So we actually have implanted an 83 and 84-year-old, and they're still going well with us as they reach 90 years of age. But of course, our standard candidates come in around in their 70s or 60s, and we do have some early age onset Parkinson's come in and being implanted in their 40s and 50s, and we even had one individual who's implanted at age 36. So, and for some of the other movement disorders, such as dystonia, often they hit hard during the teenage years, and some of the individuals can be implanted on average around 12, 13, or if it shows up as an adult, even as young adults in their 30s. And so age is not that much an issue, as well as how well do you do at that point in your life, and whether you could undergo the surgery and not have that many issues, or if there are issues that we're able to work around them. So that's kind of it for the diagnosis aspect. And again, this is to highlight a bit of our process. As I mentioned before, you have a long conversation with our movement neurologist, as well as the assessment. The dopamine challenge I mentioned is a separate session. We also wish to get an MRI obtained of just your brain in general to see that there's no abnormalities that we need to deal with, or that could also contribute to the Parkinson's symptoms, such as some vascular damage or white matter loss that again might help masquerade as Parkinsonisms when it's not true Parkinson's. And as well as that there's no abnormalities in the conformations of how the brain looks, such that our target sites are where we think they should belong, and they have not been shifted over by something as a tumor, which could also lead to differences. And throughout all this, there'll be multiple visits, as well as trying to work with you to know what you can expect in terms of benefit and outcome for your individual case, such that there's a good matchup between the symptoms that you experience and the symptoms that we are better able to manage. So that's kind of it for the diagnosis and the candidacy. I'm happy to entertain questions about that, or we can simply move on to the surgery part, as you wish.
Questions for Dr. Hargrave?
Yep. I can hear you. We've lost connection. I'm simply going to move on. I hope everyone can still hear me. I think I've lost contact with Mr. Koyala.
I hear you.
No,
Okay,
I'm fine.
good. I'm going to move on to the surgery part then. And so, of course, as I mentioned, there's really the stage 1, which is the main surgery, followed by a stage 2, but there's also a bit of pre-surgical workup, in particular, a sedation MRI the day before the surgery itself. And that's again, so we can get a map of your brain specifically that we can load up into some of our software that will be able to navigate towards targets, which will then fuse with the day of the surgery itself. And so again, on the day of the surgery, we'll be identifying the target location through our navigation. We'll be placing a frame, which will give us some external landmarks. Then we'll whip you down for more imaging to the CAT scan, which is a lot faster than the MRI. And then, of course, we'll basically bring you back, put you on our surgical table, lock in the frame, and then we actually do the targeting, set it up with the frame, set up the micro recording. And then once we're satisfied with the passes and the trajectories that we're in the correct target, and we're happy with the target location and quality of the target, then we'll actually put in one of the stimulating leads that will be permanently indwelling. And then we finally run some test stimulation in it to ensure that we can get some benefit, as well as no adverse effects. And if we do, should we shift it a little bit or move it slightly? And then once everything is all sealed up on the same day, we're going to get a confirmation, a post-operative MRI. So it's a pretty long day for the first stage. Then typically within a day or two, you'll be sent home. And a week later, you'll simply come back for a pretty standard surgery where we actually put you under full anesthesia and we add the extensions to the brain leads on the scalp and run them down the side, and then place the generator here as well. And again, that's typically a same-day procedure. So again, in a bit more detail of what we're talking about, we bring it down to the MRI the day before. It'll be under sedation, so there'll be a anesthetist involved, monitoring as the MRI happens. And again, hopefully we get some nice pictures showing up where we can see the STN on both the axial, coronal, and of course that will then get fused into the Stealth, which is a navigation system. Mainly working with software. The next day at the start of the surgery, we essentially place you in the frame itself. And of course, in attaching the frame from here dangling to beginning to mount it, of course, you're under sedation. And so our candidate here is not feeling anything. He's pretty much asleep. And then we also then add on what's known as the luminant or the halo. And that again, you can see the etchings maybe in the side on the detail that allows the CT to pick up the external landmarks that we were talking about, that you can have a Cartesian plane dropped onto the individual images of your brain, allowing us to know where the center of the frame is, which allows us to see where the center of the brain is, and then navigate away in millimeters in 3D to find our target sites. Of course, that's just our CT there. Again, you notice that they have the luminant on. That's still the day of the surgery. And then we bring you back and lock you onto the bed such that the frame gets locked in position. The luminant is now gone. We, of course, are doing a couple things here where, we have our anesthesiologists at work. And again, we sure work very hard to apply acceptable block, which is what he's doing here, to ensure there's no localized pain for when we do lift the sedation and have you awake. Just when you do wake up, and just to keep you a little bit calm and hopefully in familiar surroundings, we do create a playlist, a personalized playlist for yourself that we run in an iPod. And so when you wake up, hopefully you've got something to work with and just something to do to keep you occupied, as opposed to wondering what's going on, wondering how it's going, and listening to our conversations back and forth. So of course, this didn't show up the way it should. There's one picture missing. This again, we were talking about the navigation. There again is working the Stealth. There's one picture in detail on the Stealth of what it can really do. There's Dr. Danish working out the Stealth where he's again fused the CT imaging with the day's previous MRI. You can see some of the lines. Those are the trajectories that we're working with. And again, the whole point is once you find the targets, you're kind of drawing away from them using leads like this in the software. It's kind of like having swivel sticks that you move around to the optimal position for the trajectory, such that you don't go through certain parts of the brain that we want to avoid, but we still manage to get to the targets. And then, of course, we're hooking up the recording system. You can actually see the frame here that we had mounted, and myself running the electrophysiology to identify the recording using the microelectrodes remotely from a distance, meaning 5, 6, 7 feet away. But again, I'm on the non-sterile side of the surgery, talking to the patient on occasion and listening to the brain as we go down and awaken the patient during this part to listen to the brain. Again, another reason for the music playlist, so they have something to listen to and while away the time while they're lying there. So again, just to show a quick example of what we're talking about, we have a lead that we would run down, we hit certain tracks, and we're able to identify, if this shows up, see if you can hear this.
1-year warranty and everything.
That's characteristic of the zona incerta. It's almost like you're in between radio stations, you're just hearing static. It's largely fibers, and so you don't really hear individual units going off. But if we go down further, we basically hit the subthalamic nucleus target, which is one of our targets for Parkinson's, and there everything just rattles along erratically. It sounds a bit like this. All the bits and pieces of popcorn identify individual unit spikes, and they're basically pretty irregular and actually have fast frequency bursts. And of course, you're listening to lots of them. We're not just listening to an individual cell within the nucleus. We don't try to isolate units. We just listen to what we call multiple unit activity. And then, of course, we exit out the target and enter into the structure below, the substantia nigra, and we often try to capture that just so we know it helps identify in the positioning of the subthalamic nucleus where we are, as well as it has its own unique pattern and sound to say we're clearly out of the subthalamic nucleus. And there it seems to appear to have more of a constant train of firing, such that it fires like a machine gun at set intervals without the irregularity, as you can see with the subthalamic nucleus. So that's what we use the MER for, to identify where we are when we enter into the subthalamic nucleus and when we exit. As well, we use it to identify the quality of the subthalamic nucleus and whether we need to make another track to say that we didn't get enough of it, we need to be in a slightly different portion of it, and so on, whether we need to adjust that. And then, of course, apart from the MRI navigation, apart from the MER recordings, we also have some other visual navigation. So you may see the frame here as we're setting it up. It has what we call rings that shoot through the center on either side using an X-ray type technique that can show up. So here you can actually see the crosshairs in the double rings, meaning that it's well centered, and the lead itself being placed through the center of the crosshairs. And so wherever our target site is, will always be at the center of these rings, because that's how the frame works and is manufactured. And so a way we have converging lines of evidence from the navigation, from the MRI recordings, and from the visual placement to identify that we're in the correct target. And finally, of course, we actually attach an external simulator and run it through, and we do a bit of testing to see, can we get some benefit for the Parkinson's symptoms, as well as if we go up high enough, what are the thresholds to identify any adverse effects, such as like dizziness, from the cramping of the face, meaning that we spilled into the internal capsule. And hopefully those two thresholds are very different from each other, indicating that once we work with the programming system, we'll have a lot of room to work around and do the adjustments. That's really it for the stage one. Again, it's typically an overnight stay, and you'll leave sometime by noon the morning. And of course, later on the afternoon of the day of the surgery, we'll go through that second MRI to, again, the final confirmation that the leads are where they belong and that where we wanted them to go. And then again, you go home, have a few days and nights to calm down again and get everything going, and hopefully actually experience what we call a honeymoon effect, where some of the swelling around the leads that we have just recently placed actually act as a disruption to the pathophysiology causing the Parkinson's, which will actually alleviate the symptoms themselves. Now, of course, over time, this goes down, and that's a point where we try to get the programming up. But before that, a week later, we bring you in to run a more traditional surgery under full anesthesia, where essentially we reopen up the incision, attach the extensions to run down underneath the scalp and neck, and attach it to an IPG or an internal pulse generator subclavically or infraclavically underneath the collarbone on the chest, just beneath the skin. And so again, minus day one, we have the sedation MRI, the day of the operation itself. Again, we go to ICU care, and then day 1 and 2, discharge home. And in between there, we do the post-op MRI, which I forgot to throw in. And then a week later, day 8, battery implantation. And then again, almost 10 days to 2 weeks after the first stage 1, basically come in, have the incisions examined, have all the staples removed and the sutures. And then 2 weeks from that, we actually start the initial programming. So now the surgery part is over, and now we're going to move into what we call the post-operative management. And the initial program is about the biggest session. And what we're doing is we've implanted a lead very similar to this. A lot of them, virtually all the companies available now, have the 2 middle annular.
Well, I know that, but as long as they're nature jobs, or, no.
It's okay.
Somebody's got their, somebody didn't mute.
Someone's having a good conversation about what they're going to have for dinner. Again, as I indicated before, the second and third contacts in the first and second position are actually further broken down. If you took a cross section through it and turned it over and looked at it, it would look like a Mercedes-Benz sign, such that you can get what is now known as true directional tuning of this stimulation, which is a further advantage and allows us to even lower the stimulation lower, because we can now have better control of steering it, or current steering. But regardless of that, during the very first session of programming, we're trying to find which of the 4 different levels is the best position. And so we turn on this stimulation at fixed parameters except for one, and then slowly increase it systematically until we get some benefit, as well as increase it further until we get some side effects. Kind of like we did during the intraoperative testing in a very quick fashion, we're now doing it more systematically, and then that will help define a window of opportunity for programming for each of the contacts. So let me just run through an example. We turn on the stimulation, we develop a little stimulation sphere. It's more shaped like a donut, but spheres in PowerPoint are easier to draw than donuts. And again, we systematically increase it, and it keeps increasing. And we have our first threshold, which I jumped by. Then eventually we get an adverse effect threshold, and that's where we would stop. We would not keep pushing beyond that on that contact. And then that then helps define a window of programming for that contact. And now we want to do the same for the other remaining 3 contacts to see where those benefits happen. And this is just going to play out by itself. Obviously, it's time for me to get a new machine. Should go faster. I think my wife's machine here is now close to 10 years old. Actually, it is, so. But it still works well enough. So hopefully it should be clear that this is the largest therapeutic window, and that would be the contact that we would select for use in the initial programming. Then we would do a bit more fine tuning, and then we would have you take your medication during that first session to see how the DBS works with your medication. And when you take the medication, we might already recommend that you lower some of it or don't take the full amount to push you over into what's known as dyskinesias, or often a symptom of too much meds, which before may have been required to get you good, to have that side effect, but now hopefully we're going to work towards not having the dyskinesias, but still have the full benefit that you had from the meds before because of the DBS. The different parameters we can play with, of course, are the strength or the amplitude of the square waves, which is what the device actually does. An internal pulse generator, it generates pulses. Those pulses are square waves. And so, of course, if you increase the amplitude, the waveforms are just going to get taller, and that tends to relate to the stimulation field getting larger. And we can also then play with the pulse width, which tends to shift what we call the intensity of the field. It still make it a little bit larger, but not in the same fashion. So it's almost making it thicker and denser. And again, we often show our stimulation as though there are edges to the field. It's not quite true. Electrical stimulation in biological tissue very much works like light from a light source. It has an exponential decay. But of course, we assume that there's a reasonable amount of impact or effect on the tissue itself, which of course is different from the neural elements of the different cell bodies, interneurons versus the principal cells, like the spiny cells within the subthalamic nucleus itself, or fibers of projection. They all have their slightly different curves. And what you're doing when you increase the amplitude is you're shifting that curve arithmetically, sliding it up and down. Or second, when you change the pulse width, you're actually changing the slope of that nonlinear curve. And that's, again, how we can shape the stimulation field, kind of blindly because we don't get to visualize it, although now a lot of the software packages that can work with the programming modules are working towards a visualization of your particular MRI and the position itself, and hopefully a visualization or modeling of the stimulation field, which is one of the ways we can work towards future guiding the stimulation. But of course, the biggest thing we want to work with is how does it impact your symptoms and work with your symptoms, as well as alleviating any of the side effects either from the stimulation or from the medication. Now, I think we're into some, oh yeah, we're still going to do one last thing, looking at the frequency. And this is sort of the wild card in here, in that it doesn't work the same way that most of the other programming parameters to be adding to it. It works with different symptom clusters. And of course, pulses per second, we work in hertz. And of course, or faster pulses and pulsing. And of course, certain symptom clusters such as tremor are better controlled by higher frequencies. If you do not have tremor dominant form of Parkinson's, you can often work with slower frequencies around 130 hertz. Again, if you mainly have some gait issues, we found that they work best at the lowest frequencies, but it's rare that anyone has one unique set of symptoms and that's it. Often it's a mix. And so we're often taking the frequency and trying to bounce between those symptom clusters. So we mentioned the post-operative management. There are going to be a number of visits. So what you're looking at here, all the blue lines, each line is an individual over time from left to right, from the beginning of the surgery to the end of 4 years. These are real data from our samples that we presented before at scientific meetings to show how things are displayed and what our averages are. And as you can see, each of the blue dots is a visit. So here during our first year, during the first 6 months, you've got a lot of little visits. Short intervals as we drag down the meds and increase the stimulation and try to make it work with you, as well as, again, you can see that some individuals have what we call a few hiccups working with the meds and the others, whereas others actually have a pretty easy, graceful period and move straight through, have a little cluster, and then all of a sudden they don't need to see us at all. But on average, you have about 10 to 12 visits during the first year, and most of those, 8 of those 12 visits, occur within the first 6 months. Once we move to the second year, we drop way down to about maybe 2 visits, and so basically 1 visit per season on average. And again, you can see some people only show up every 6 months because they don't need it, and others, again, somewhere down the road run into a few little hiccups that we need a few very closely placed sessions together to come in and do it. Now, since COVID, there's 3 companies that create DBS systems. We employ them all, and we try to get the advantages and disadvantages of the different systems and match them to the individual. So some work well with independent frequencies because Parkinson's can be fairly asymmetric in the disease state, meaning that one side of the body is largely affected and the other one hardly at all. Whereas, of course, later on, we expect that unaffected side to begin to be affected equally. But sometimes we can actually have stronger stimulation on one side, much weaker, and that will also work with the frequencies. And so some of the systems are better at independent frequencies on each of the hemispheres, whereas others work with harmonics of a principal frequency and are a bit more limited in that regard. At first, Abbott was one of the first companies to develop this idea of the segmented lead, although it was truly in the realm of Medtronic, first of all, but they abandoned it temporarily to chase an even more sophisticated lead, which did not work out, known as the Leopard. And then of course, that means they came back and have recently released their segmented lead and gotten FDA approval for it. So a number of the companies that came out have provided competition for each other, and their systems and advantages are becoming less apparent as they produce the iterations of the different devices and compete with each other and move towards something more similar. But regardless, although the data I'm showing you here on the individual patients is largely from all the Medtronic individuals, or just a few of them, it's a subset that we've been following for some time. Yeah, so quickly in a nutshell, we have the connector and the extension, the lead during the surgery. Place it in, then afterwards we're able to program, ignore that little graphic, and then we turn on the stimulation as we suggested. Okay, our team itself, in terms of how many have we actually done? Again, we're now at Jersey Shore. We've done almost close to 10 surgeries since we've arrived, but prior to that, the team as it exists and the individuals were at another institution, and en masse, we almost moved here and are still working together with the same individuals. So all told, we've actually come close to 250 individuals that we've worked with and dealt with. And of course, that also means device exchanges. We're up to close to 275 of those, which brings me to another point, because we have standard batteries, they run down. What do? You need to exchange them. We'll just get to that in a second. And so again, just using some of our Medtronic data, we show that devices tend to expire in our hands and our programming close to 4 years. That's what the blotted blue line is. Of course, as you can see, some go beyond that, and a few are short for that. And a certain threshold, when they're too short, and around this range, we might actually opt for some of the different abilities of rechargeable, such as the Medtronic RC. The Boston Scientific has a rechargeable, and again, the St. Jude or the Abbott is working on their rechargeable, soon to be released. So I guess I'm not going to go into a lot of the details of the different systems. Needless to say, there are 3 existing DBS systems out there that are FDA approved. We do implant all 3 and have sufficient experience programming with them. And although there were some initial advantages to some over others, those are merging over time. So again, I mentioned the segmented leads. Now both Boston and Medtronic have the segmented leads as well. Different interfaces. We're all used to them. And I guess this is just one of our examples of an individual who's willing to be videotaped. This is actually Lewis. How are we doing for time? This will be about 2-3 minutes.
About 10 minutes of that.
Okay, good. So this is off, and Lewis was an individual being implanted about a year before. He was kind enough to come in without his meds and just run on the DBS. And without the DBS, this is as bad as his Parkinson's is. And of course, you can see the tremor starting up right away. That was Deb Caputo who actually just deactivated him. You notice the mask-like quality in that his facial features have the bradykinesia. They're no longer as animated as his normal personality is. We'll see some of the hands start ticking and you're really tremoring a bit poorly. See if we can advance it a bit. Again, we're just going to run through bits and pieces of what we call the Universal Parkinson's Disease Rating Scale. He's doing finger taps. And you notice again, there's a great attenuation, meaning it started out big, and then it quickly went to small. You can see how slow his opening his hand is to a full extension. A bit faster there. Now I think we're going to actually try to have him stand up. Oh, he's just going to watch the tremor come out. You can see it kicking up once we put in that position. When he gets a little bit closer to us, of course, you actually see he has a tongue tremor too. He's going to try and help him stand. And of course, he needs 2 attempts to get up. He's going to take a few of those small shuffling steps to us. You can tell there's a stooped posture. I think at some point I zoom away. Yep. He's going to make his turn. And basically baby steps all his way back to the chair. Not exactly a happy camper. So we're actually quite grateful to Lewis for allowing us to do this and show people. Then of course, almost instantly you see he's being activated already, and you can see instantly, even from the tilt of his head and from the look on his face, that he's going to be a little more animated. He's able to orient, move around, start talking with his hands again. Again, that's exactly what we want to see on the finger taps. No decrement, nice speed. Open and close, boom, boom, boom. Bradykinesia is like magically lifted. Yeah, the extra turning of the light bulbs. Here we're working from the fingers to the wrists to the arms in terms of the mobility of the different joints. He's going to do some toe taps for us. You got to do it on both extremities, both upper and lower. And of course, he's going to bounce out of that chair. Now this is where he's going to show off for us. He's going to do a military turn and almost keel over, just because he's trying to show off for us. Almost. And then just because I teased him about that, he has to assault the cameraman. But yeah, and then other times he's actually dropped down and give us a few push-ups. So quite a difference. Anyway, and that's Lewis. And then we're happy to answer some questions, and all of us joining in. Yeah, questions?
Doctor, what are the different risks associated with the different stages of the procedures?
Well, when we're sticking stuff in the head, there's always a chance of some of the lesions or edema, which will be transient and go away. There's also a small chance of hemorrhage. In our 240 individuals, I think we've had 2 hemorrhages with clinical symptoms, and that's it. So we're actually below the national average, and we're quite proud of that. But right now, in a way, the surgery is about as safe as it's going to get. So a lot of the numbers and classic numbers done in the big studies done prior to 2010 had some of these instances higher than that. And basically all the techniques of the surgery that have improved have basically improved the safety of the surgery down to where many centers are more like us. But we're also a center that wishes to do a relatively high volume. You do want to choose a center, regardless of whether it's us or others, that does at least 12 surgeries a year. It requires a group of dedicated people working together as a team. There are some other centers around where you might have an individual neurosurgeon who does maybe 2, 3, 4 of these surgeries a year, and he needs to walk into the OR and say, okay, you, and you, can you come with me and we're going to do this type of surgery? And they're not working together as a team on a regular basis. That makes a really big difference. And so, again, as I indicated, when Dr. Danish decided to move and transplant the program, he invited a number of the key people that he thought he wanted to help keep the program here. And so in mass, we left our last institution because of the offers that were made and dropped the whole program right down here.
Can I make a comment here to that question? The question was about, risks associated with procedure. General risks of brain surgery are infection, bleeding, stroke, and infection. So I think along those lines, the risks are, low, but they're never zero. It'll never be zero, as Eric said. So, and I think, quite frankly, if you decide that this is the path you want to go down, nobody ever not does it because the infection rate is, 4% and not 3%, or the bleeding rate is 0.5% and not 0.25%. So I think when that time comes, we'll chat. But as Dr. Hargreaves stated, the techniques are extremely well refined. Risks are low. And look, when I started doing this as a resident, people stayed in the hospital about 5 or 6 days. Now, people stay overnight. And very soon in the future, this is going to be an outpatient procedure. So.
At what stage of the clinical appearance of the disease, or the stage of the disease, should patients consider having the surgery?
I'm going to take that one too, Eric. So I'd say that when you start exhibiting symptoms, or you have a diagnosis of Parkinson's-like or movement disorder, I think the earlier you meet with a surgical group, the better it is. It's not about tying you off to a bed and whisking you off to surgery, but it's about the process of education. So you can understand your options, what exists, what are the treatments that are available, whether they are relevant to you at that moment or not.
Thank you.
More questions?
I have a question about the lead. Could you explain more about the lead and how it works with once it's activated, and once it's surgically implanted, you never go back and adjust it?
So,
I mean, once
hi,
it's set.
Michael.
Hey, Eric, how you doing?
Yeah. Once we implant a lead, if it's where we wish it to be, we never want to go in and change it again.
Okay.
However, we have had instances where we inherit individuals, typically within their first year, that they've been dissatisfied with how their DBS system has been performing for them. And invariably, we try to get an MRI to indicate where are the leads in case there was a misplace or a displace. And invariably, we find that the leads may not be optimally placed. And in that case, we've gone in again, typically within the first or second year, to shift the leads or pull one out and do it all over again in terms of the actual leads. But often we're able to attach it to the existing system, so it's not going through the whole process from scratch.
Okay.
It's very rare that we have to go in and adjust these. And there's also sometimes, leads fracture, people fall, they hit their heads. There's that other things that happen, but it's a very rare occurrence that we're doing lead revisions for misplaced leads.
And
Okay.
most often, it's often the device or the extensions that get fractured
Right.
during an incident or a fall. And
That
therefore,
is
again,
amazing, yeah.
we're able to leave the brain leads themselves untouched.
And the battery packs are essentially interchangeable from manufacturer to manufacturer, or?
That depends on the different companies. I'm actually going to allow Alicia to speak to that for her company. She's just going to chime on in a second.
So when you say interchangeable,
Well, if
depends
you-
on what
if you
exactly
feel-
you mean.
Well, if you feel like you're not getting the optimal performance out of,
Hold on 1 second, sorry. What was that you said, Michael? I couldn't
I
hear
said,
you.
if you feel that you're not getting your optimal performance out of the battery pack that you have that was implanted with the surgery, can you opt for one of the different? There's only 3 or 4 different manufacturers, right? So if
Right,
one or the
there are
other-
3, sure, there are 3 manufacturers, and in general, with deep brain stimulation, we don't recommend that you interchange. It in general is a good idea to have all one singular system, from the leads in the brain to the extension to the battery in the chest. There have been, cases where people have we call it mixing systems. But I think in general, that's not necessarily preferred.
Okay.
So, the answer to that, I know that's not a clear-cut answer. It's not an exact, absolutely not. But again, it's not recommended. And, when you talk about the performance that you get out of the battery, or your expectations, the beauty of all of these systems is that if you get a skilled clinician that knows what they're doing with the programming, there are just so many different things and techniques that they can employ to try and best keep up with your motor function symptoms. So, if you're programmed and then your disease progresses, as unfortunately Parkinson's does, the nice thing about deep brain stimulation is that your clinician can continue to change and alter and tweak the programming. Now, programming has become very personalized with the way, the technology within the batteries are structured. So, I would say that hopefully the system that you go with from the beginning would be the one that you would stay with, and that most importantly, find a skilled clinician that can continue to make those adjustments to keep up with your disease, so that you're not in a permanent state of displeasure with your system.
Okay.
We've been doing this for, we've had multiple systems out for a little while, and I'll tell you, I myself as a surgeon have never cross-matched systems. If a patient is not doing well, I think a new generator or different sort of wires that's not going to be the solution. The solution is that you need to find somebody who takes the time to understand how to manipulate the parameters and how your symptoms are responding to them. And quite frankly, as Alicia said, there are actually not a lot of those practitioners around.
That being said, Medtronic has taken the principled stand, basically where they cannot convert to different systems, and decided not to do that. Whereas Abbott and Boston Scientific have decided that maybe they can, and so they've actually adjusted their header system such that they can accept Medtronic leads, but not each other's as of yet. And that's possibly because Boston was a little late on the market, so no one's competing yet with Boston in this area. At the same time, as we mentioned, and Alicia mentioned, once you have a crossed system, there is no pure FDA approval, and therefore there's no approval for MRIs. And we do often find our individuals may have burgeoning back issues that might require MRIs, and having a mixed crossed system from different components puts you in MRI never land.
Oh, okay. Oh, yeah. Yeah, that's a big consideration there, right? Okay. All right. Thank you.
All right. Hey, Dr. Dennis, I have a question for you and Eric as well. Now, you mentioned earlier that the best thing to do when it comes to the early intervention is to locate a place where it's going to be like a multi, what do you call this now? Multi specialty system whereby during the evaluation.
You want to pick a place that's going to be convenient for you that has the expertise.
All right. Okay. Now,
But sometimes you are, traveling, quite a bit, and you also, you need access. So.
okay. My question to you during the part of the evaluation then, that part of the evaluation, am I going to be evaluated by your crew or how does that work?
Where do you, so tell me a little bit about
All right.
who is the neurologist who is currently managing your care?
I am right now with JFK.
Okay. And look, if I would say you should be evaluated by the group that is going to take care of you long-term. So if our group, for example, is going to care for you long-term, then you should come be evaluated by us.
Right. I see. Okay.
It's rare that we take on spec other neurologists that we're not familiar with. So if we do get referrals, we like them to run through our detailed process. We do have collaborations with certain neurologists in the community who we've worked with before on a number of occasions, where they may start the process and recommend it, but then we still finish the process, such that the dopamine challenge, for example, is always done here. The MRI evaluation will always be done here. But sometimes the initial history, the initial diagnosis, and all the meds that have been tried may be performed by your neurologist that you're already seeing. And if we know them and have the records available, we may tend to work and trust that.
Okay. All right. Thank you so much. It's a very important information for me right now. So thank you.
Any other questions out there?
I have one. Can you be a candidate if you don't have a very strong tremor and your fascination, your gait is really rough?
I think it's hard to sort of make a definitive statement based on somewhat hypothetical situation. In general, I would say that if you have a reliable response to your medications and you experience on and off with those meds, meaning you turn on with the meds and turn off with the meds, then you absolutely should be talking to a surgical group about whether it might benefit you. Gait is a tough set of symptoms, and I think it really depends on what is the source of the gait disturbance. But it is not just, there's a common misnomer that this surgery is only good for tremor, and that is not a true statement.
Thank you. Anyone else?
And all the surgeries, doctor, is done at Jersey Shore, right? Jersey Shore Medical Center. Is that where your office
Yeah,
is?
so as Dr. Hargreaves had mentioned, we were extremely busy group in New Brunswick. And so I brought the entire surgical team and a lot of the outpatient team with me, in addition to adding more, expertise from places like Stanford with Dana. So I think, we are, most of these teams are operating just in one hospital. So I'm very confident in this hospital system. It's not just the operating room team, but it's the ICU team afterwards and the care team and the outpatient practice that allows for, patients to get through this safely. So that happens here.
All right. Okay, thank you.
Okay, and I would urge, John, I appreciate the opportunity, for us to talk. I think this is always about making connections and, providing an ability for people to have an open forum to, to talk, to listen, to exchange questions and ideas. So, we are all here as a resource.
Hey, John, if you could let Eric share one more screen. It's just their contact information for the team at Jersey Shore so that everyone can kind of jot it down. If they want to reach out to the team later to ask questions or schedule a visit or something like that. I can, yeah, just make it bigger, put it in presentation mode to make it, there we go. There we go. So if anyone on the call wants to ask any other questions that they think of later, or get in contact and come to see any of the clinicians, you can see their website is here, a lot of good information.
So the office number, if you ask for Dana, that's me. I'm not in Alicia's screen. Oh, there I just appeared. And then that is our direct email, which I also answer. So I'm your main contact person. If you have any questions, concerns, want to come see us, just want to chat, I'm here for you. Okay.
Thank you.
All right.
Okay, then I guess there's no more questions.
John,
Very
there
good.
you are.
Hey,
Okay.
John, there you go.
Hey, John,
Yeah,
Is
Okay,
there
again,
any-
we'd like to thank you for allowing us to present the information to you, and happy if there's any final comments or any final questions.
is there any way you can send us this thing that I'm looking right now, the contact information, John?
yeah, sure. This entire presentation will go on the website.
You guys, I want to thank, thank you, Dr. Hargreaves, for, putting together an informative talk, and, Dana and John for, being, and Alicia for helping to always, get patients and families, together in a place where we can have these conversations. So, again, we're here as a resource, all of us. We want everybody's quality of life to be the best that it can be.
Thank you, Dr.
Everybody deserves that.
Thank you.
Thanks,
Thank you.
everybody. Have a nice night.
Yeah.
All right, thank you, John.
Thank
Eric,
you.
Thank you so
everyone.
much.
Thanks very much.